Now where are we? We are on neural tube defects. Excellent. I'll duplicate my screen. Let's see. Right. So look, neural tube defects. Let's start with the acrania, which can also be exencephaly or anencephaly. From acrania to anencephaly, it's a one spectrum of the condition. The genesis of the condition is that there is absence of the cranial vault. So in the beginning, if we scan babies at 11 to 12 weeks, we will see that the brain is there, but what is missing is the cranium, the bone structure is missing on these babies. If it is just the absence of the cranial vault with the visible cerebral hemispheres, visible brain, we call that exencephaly or acrania. But when there's complete absence of the cerebral hemispheres, which becomes anencephaly, when you follow up babies, or you see that at 11 to 12 weeks, it is not common to see anencephaly at 11 to 12 weeks. But what you are going to see is more for an acrania or an exencephaly kind of situation, whereby the brain is there, but the skull is missing. But due to continuous exposure to amniotic fluid, if these babies are scanned at 30 weeks or 32 weeks, you're not going to see any brain because the brain is autolyzed, is dissolved over time. It just undergoes autolysis and disappears. And what you are going to see is an absent brain structure. So acrania and anencephaly is just one spectrum of the same condition. That's acrania and anencephaly. Acrania or anencephaly is a first trimester diagnosis. We should pick it up in first trimester, not in a third trimester like what we are doing. It is wrong. Then in terms of how common it is, of course, it varies geographically, but one of the most determinant factor in terms of the prevalence is the consumption of folic acid by expecting pregnant women. In regions where folic acid is not being widely used preconceptually, the instance of acrania and anencephaly is very common, is very high. But in regions where there is widespread use of preconception folic acid, then the prevalence is very low. The UK reports about 5 per 1,000 beds of acrania because the culture of taking preconception folic acid is also very poor in the UK. So when should women take folic acid? Preconceptionally, whenever they decide that they want to have a baby, they should start taking folic acid. There is a wrong teaching that has been perpetuated for so many years, which some of us were taught, probably the majority of you here were also taught, that women, they should be given folic acid when they come to book with us. It's too late. The brain is formed around 5 to 6 weeks. Before the woman even knows that they are pregnant, the brain is already forming. So if the cranium didn't form, it doesn't matter how much dose of folic acid they are going to give them. From 12 weeks, 16 weeks, no matter how many weeks, it's not going to matter. You have missed the boat. So remember this, because this condition just requires health workers who know what they are doing, who know what message to package to women who want to try and have a baby. So women should be told that they take folic acid the moment they just think that they want to have a baby, not after they've had a baby. It's too late. What causes it? Of course, the causes are multifactorial. But there is a pathogenic link with folate deficiency and also homocysteine metabolism errors. That is what caused the condition. The diagnosis is very simple. The absence of the cranial vault. This diagnosis will always clinch it if we all do the BPD plane in first trimester. As long as we try to take the BPD plane, we'll never miss an acrania, and we're not going to miss even an anencephaly in rare circumstances whereby probably there is rapid progression. So acrania is a first trimester diagnosis, not a second trimester diagnosis. Of course, because our women present late, most of our conditions were picking them up from second trimester all the way to third trimester. And the frog's face sign is what you see in cases of acrania. I'll show you the images, how they look like, very funny. And you also miss the BPD plane, the BPD head circumference plane. You try to measure the head circumference, but you are not going to succeed because the anatomy is abnormal. Chromosome abnormalities, in isolated cases, they occur at a rate of 2 to 3%. How do we manage? Termination of pregnancy is a viable option because there is no baby without a brain who is viable. Yes? So there is no baby without a brain who is viable. So when you see an acrania or an anencephaly, you refer to fetal medicine so that we can offer this woman termination of pregnancy. You don't tell a woman that something will change or come back in 4 weeks and check things again. Well, this is what women are being told sometimes. So just know that women with anencephaly should be offered termination of pregnancy as an option. I'm not saying all pregnancy should be terminated. Please get me right, because some women will not accept it. Some women will say, look, doc, I don't accept termination where I come from, and I would like my pregnancy managed expectantly. But women should always be given an option. There's no woman in modern times who should carry an anencephaly pregnancy to term because she has not been given an option of termination of the pregnancy. Because the challenge with this kind of pregnancy is that there is a missing skull vault there. What normally makes women, the cervix open is the pressure exerted by the cervix, on the cervix by the fetal head. So the absence of the fetal head complicates even natural labor for the women with anencephaly. So that most of these women may end up actually getting a cesarean if they go all the way to term, and they tend to surpass the term anyway. They will have polyhydramnios, they will go beyond term, they may even rupture membranes early, they may even get pulmonary embolism, or not pulmonary, but amniotic fluid embolism from rupture of the membranes because they normally have polyhydramnios, and the babies are more presented. So in certain centers, they may end up being sectioned, having a cesarean section to deliver an anencephaly. You can imagine the trauma. But if the pregnancy is terminated early, it becomes easier because early a surgical evacuation can be done if labor doesn't progress, because the baby will be small enough. So let's remember this. So the prognosis is poor. The condition is incompatible with life. There's nothing like something can be done. Please take note of this. Anencephaly, acrania, exencephaly, all these are lethal conditions. There is no baby who walks around in any part of the world without a brain. Please take note of this, because women have to be told the right information. If you tell women that there's a chance, then in that case, there is a problem, because you are going to give hope. You are going to give hope where there is no hope. So please take note of this. Go to the next one. So look, this is how acrania will look in first trimester. But look, I know this image can deceive some. and they'll think there's a scalp. But don't worry. If you think there's a scalp, then try to get the BPD. You are not going to get a classical BPD with a midline and the choral plexuses, a first trimester BPD. So do not worry. I know this image is deceiving a lot. Even in this country, most women we see with anencephaly third and second trimester, they will have had a first trimester scan which was reassuring. It's because people see this and think there is a scalp there, yet this is just skin. So don't worry about this image. If you can not tell, you go and try to get a BPD. The BPD will be your answer to say, do we have a skull or we do not have it? So you can see here that these are frog's eyes. It's looking like frog's eyes, right? When you look at the image. So it looks like frog's eyes on the image there. So that was acrania. Then we go to open spina bifida. We call this also myelomeningocele. Very educated term, right? Myelomeningocele. So how common is it? As common as 1 in 1,000. It has got the same etiology as acrania. Deficiency in folic acid. If women do not take folic acid preconception, they may end up with open spina bifida. So we have to tell the women to take folic acid preconception. The moment a woman decides that I want to have a baby, they should start taking folic acid. How do we diagnose open spina bifida? Indirect signs include the lemon sign, the banana sign, the effacement of the cisterna magna or the obliteration of the cisterna magna. There will be no cisterna magna space to measure in cases of open spinal bifida. Then we may see ventriculomegaly. Normally, this is a late sign due to the obstruction at the level of the foramen magna. So this is a late sign. Then we have the direct signs. The direct sign, we may see a C or a U shape at the level of the affected vertebrae, an interruption of the cutaneous corridor or the skin. The skin is interrupted, the skin covering. When you look on the ultrasound, when you do that sagittal image of the spine, there may be or there may not be a meningocele. Meningocele means the spinal cord fibers are outside. The meninges that cover the spinal cord are outside or within the sac of the myelomeningocele. We may also see the splaying of the lateral processes. I'll show you on the images what we mean by splay or the opening up of the lateral processes. Whenever you see an open spina bifida, go and look at the feet because it's commonly associated with the talipes due to the tagging of the nerves. So the legs do not grow properly, the foot do not develop properly. So you end up with club foot. That's talipes, remember, club foot. The bladder may be distended because if it is a lumbosacral, the bladder sphincter control is affected when those nerves get damaged. So the bladder may be distended. Then we can also have hydronephrosis, but this is secondary to bladder distension. So these are some of the features to look for whenever we come across a case of open spina bifida or myelomeningocele. Chromosome abnormalities, they may occur in 8 to 16% of the cases, but normally this occurs in associated cases. In isolated cases, rarer than that. Obstetric management, karyotype may offer it if it is not an isolated case. But if the case is isolated, there's no need to offer karyotype. And of course, we have to exclude other abnormalities. This is why it is important for all these cases to be seen in the fetal defects clinic. The reason for seeing cases in the fetal defects clinic is not to say people who have seen a myelomeningocele cannot diagnose a myelomeningocele, but it allows us to rule out the other defects. Ruling out Ruling out other defects is very important. Because it will allow us to cancel the woman the possibility of an underlying chromosome abnormalities, and also the recurrence risk whenever there's a chromosome abnormality. As you are aware, whenever there's a chromosome abnormality, so the case, the recurrence risk could be 1% or more. So we have to warn the couple so that they know what to do in their next pregnancy. So this is very important. I did not go downtown because I'm not covering myelomeningocele as a topic. But one of the most important things when you are looking at the myelomeningocele is to determine the level of the affection. The level of the affection will allow us to know what counseling message we give to the couple. For example, if it is a thoracic myelomeningocele, we know that this kind of condition is nearly because the morbidity is so much, and these women can be cancelled towards termination of pregnancy. If it is a sacrococcygeal myelomeningocele, then in that case, you can reassure the couple that the baby may walk, but may have probably sensational issues. But however, a thoracolumbar, we have to be precise so that we cancel the woman in terms of the expectation to say, is the baby going to walk? Is the baby going to control the poo and the pee? Because some couple need this kind of information to make an informed decision to say, do they want to keep the pregnancy or they don't wish to keep the pregnancy? Some couple will tell you we don't want a paraplegic, because normally if it's a thoracolumbar, we may be dealing with a situation whereby the baby may not be able to walk. Some couple may choose not to have that. So determination of level is very important. This is why referring to fetal defects clinic is very important for this kind of cases, so that we can determine the level, then counsel the patients in terms of their expectations, in terms of so that they can make informed pregnancy decisions. So these are some of the signs that help us to pick a myelomeningocele. I showed you earlier a banana sign and a lemon head, but this is the first trimester image. You can see that the brainstem looks much thicker than the brainstem to hospital bone ratio distance here. So this is a brainstem. If we were to measure this distance, you will see that this distance is way much thicker. This distance here, if we were to compare it with this one, you can see that this distance is more than one. We use this to screen for myelomeningocele. It just shows that the brainstem has been pulled downwards or rotated. This is why we do the brainstem to brainstem hospital bone ratio. When you are doing first trimester, remember when you are saying brainstem to brainstem hospital bone ratio, we are screening for myelomeningocele. I hope I'm making myself clear, because most often during the first trimester, people don't know why we are measuring the brainstem to brainstem hospital bone ratio, but we are doing it so that we can screen for myelomeningocele, spina bifida, early first trimester, because fetal medicine is about early diagnosis. We do not want to diagnose conditions late, because it has got a lot of implications for the couple and also for us, because doing feticide is never a nice, it leaves a sour taste to do a feticide, because it's not nice to, rather have these babies just be terminated with misoprostol like miscarriages, rather than to do a feticide, which is more traumatic, not only to the couple, but also to us. Is a very traumatic kind of procedure. I don't think it will be normal in the next 15 to 20 years doing this kind of thing, because it's not normal. So we want early diagnosis. So remember this. This is why we have to know that early diagnosis is possible if we look at babies carefully. So look at the spine here. You can see a clear interruption of the skin. It's not the best image of the spine. Probably we have hours after this, which are much better. But you can see there's an interruption there. And you can also see that the railway line is not continuing on this image. there is no continuation of the railway line, the parallel line there, because there is a break in that more for lumbosacral myelomeningocele. So this is a kind of ventriculomegaly. It's more like a teardrop you normally get with some call it corpocephaly, not teardrop, corpocephaly, the kind of ventriculomegaly you will get with myelomeningocele due to the obstruction at the level of the foramen magnum, because the brainstem is pulled downwards. This is a banana sign. Look at this. So you can see the cerebellum is shaped like a banana, and the cisterna magna is very narrowed. So that's a banana-shaped cerebella there. So you can see, if you don't see the cisterna magna, it's not normal. If you are doing an anomaly scan, you don't see the cisterna magna space, please don't normalize things. Refer the patient. If you don't see the cisterna magna space, even in third trimester, you are not certain, look at the spine. If you see that the spine is nicely covered, still you are in doubt that the cisterna magna is not there. Of course, we know it narrows towards term. Towards term may be extremely difficult to see. But if you see a woman very much in mid-third trimester, you should see a cisterna magna space. This fluid behind the cerebellum, it should look normal. But if it is narrowed or obliterated, then we have to suspect that we are dealing with a case of myelomeningocele. So normally there's a cystic structure. You can see the C-shaped here. This is not the transverse plane. Remember, we discussed about the transverse plane when we were saying how do we look screen for CNS defect. So you can see that there's a C-shaped, there's breakage of continuity of the bones there, and you can see the cystic structure where the spinal cerebrospinal fluid is. So there it is. And here we see another cystic structure on the spine. And this is this plane we were discussing on this 3D image here. So you can see here, normally the spine should sort of narrow towards the end. It should not be opening up towards the end like you see there. So if you see this playing or the widening of the spine, that's again another sign of a myelomeningocele or spina bifida there. And this is how babies look like when they are born. I think most of you have seen this, how babies look like with myelomeningocele. So we discussed about open spina bifida, very easy to pick. But let's talk about closed spina bifida. It's not easy to pick. So this is why we have to talk about it. The closed spina bifida, normally there are two types. We have one with subcutaneous mass or a meningocele or a lipoma. There's skin covered lower, there's a skin which should be covered in the lower spine mass, and but can be associated with the tethered cord or a hydromyelia. The prognosis is very good with a closed spina bifida. Then that is with the subcutaneous mass. Then if we close spina bifida without a subcutaneous mass, with this condition, we may have what you call a diastematomyelia, which may be complete or partial. This condition involves the clefting of the spinal cord into two symmetrical or asymmetrical hemicords, usually at the thoracic level of the spine, with the cord uniting more distally. I will show you on the image, on the images, how this looks like. Very difficult to diagnose prenatally, but it's something that we have to know and to look for and to suspect. So, so there are two types. There's type A, where the hemicord is within a single dura and arachnoid sheath. Then the type B, each hemicord is its own dura and arachnoid sheath with a bony spur or a septum separating the two. Then we have the cord tethering is suspected if the chorda equina, remember I showed you the chorda equina when we started the series. is below L4 or L5 at 20 to 22 weeks. The main complaint of this condition is that babies may have sensory neural defects if the cord is tethered. However, if the cord is tethered, it could be asymptomatic, this condition. So to just show you, this is how it will look like. You can see that this is the skin, but here there's a lipoma. There could be a lipoma or a hydromyelia, that is fluid within a hair. So this is how it looks. It's slightly different from myelomeningocele in the fact that in this case, the skin is covering. Then this is a bone spur that we normally see in cases of a hemi spine, where the spinal cord is divided. You can see there's a bone spur. We get this image when we do the coronal plane. This is why it is important to be able to look at the spine in all the three planes. That is the spinal plane, the transverse plane, and the coronal plane. So this is how we get this image. Of course, this is a 3D rendered image here, but you can see there that these are the bony structures, and then we have the bony spur, which is dividing the spinal cord. Yeah. This is a dissection image now of the condition. You can see there's a bony spur and the spinal cord is divided into two there. So that's the condition we describe, where we are saying we have a hemicord. We could have it with a single dura and arachnoid sheath, or we could have it with a separate dura and arachnoid sheath. That's a closed spinal bifida with the hemicords. So yeah. So the closed spinal bifida without subcutaneous mass can also present with what we call a caudal regression sequence or sirenomelia. The caudal regression, there's partial or total agenesis of the sacrum or lower lumbar and associated with the VACTEL conditions. We'll cover the VACTEL when we do the syndromes, because we are going to do a topic called syndromes, where we are going to cover the most commonest syndromes that are known. So that's why we'll cover the VACTEL syndrome. So then we can also have sirenomelia. The sirenomelia, there are two legs that are fused into a single abnormal limb. These ones look like a mermaid, as you will see. So that condition is called sirenomelia. I know in our region here, if a woman delivers those kind of babies, people are going to say they've delivered a njuzu or a mermaid, as you will see. Both are strongly associated with maternal diabetes. This is why it is important to check the spine whenever you are dealing with a diabetic woman. So remember this, partial or total agenesis of the sacrum is associated with diabetes. We know it's very rare because we have been examining them diabetic women. So far, we've not come across a case of caudal regression or a partial or total agenesis of the sacrum, but it's something which is listed in the literature. So we have to keep on checking the diabetic or diabetic ladies. But always remember that the defects of diabetes comes with poor control. So our failure to pick it up may also be a sign that the majority of our women may be controlling it very well. So then we also have Currarino syndrome, which is caused by, it's more of a caudal regression, which is carried by a triad of pre-sacral mass, sacral bone defect, and an anorectal malformation. So if we look, this is caudal regression sequence. You can see that right at the end, the sacrum is not very clear, the sacral bone there. It's not the best of image to show you this. It's not the best. Then this is Serenomelia. You can see how baby Serenomelia, they look like a Juzu, like a mermaid, right? It's a Serenomelia. It's actually a disorder in humans. Maybe in mermaids, if they do exist, it's normal. But in humans, it's a disorder. When you try to, when you check the lower limbs, you are going to see that the lower limbs are fused. You can see the two bones, the fusion. And you can see how the toes will look like. Everything is fused and they look like a mermaid. This condition is called Serenomelia. It's a very bad condition, lethal condition, and termination of pregnancy is a viable option for this couple, for these expecting parents. Then sacrococcygeal teratoma is extremely rare tumor, but in our database we have this. We've come across them now, I think 2 or 3, but it's a rare tumor. How do we know it? It is a large mass arising from the sacrococcygeal area. It may have an intrapelvic component or may not have it. It is actually graded depending on there's type 1, 2, and 3. If I'm not mistaken, it should be type 1, 2, and 3. Depending on their intrapelvic involvement. I'm not covering sacrococcygeal teratoma as a topic, but you just have to know that the intrapelvic involvement is a very big plays a very big part in classification and also prognosticating this mass. It can be completely solid, cystic, or it can be partial. That means it can be solid cystic. It's frequently associated with high output cardiac failure. So whenever we see this case, this mass, we want to check the vascularization. The more solid cystic it is, the more vascularized it is. The more solid it is, the better. And these babies suffer from high output cardiac failure. The risk of chromosome abnormality is very low. Whenever we come across it, we want to rule out associated malformations. We also have to do a fetal echo, and the deliveries by C-section. The reason why it has always been C-section is because there's always been a fear of decompression effect of the mass. The decompression effect is caused normally during the labor. If the tumor ruptures into the cyst, the vessels ruptures into the cyst, remember, it will be the baby exsanguinating into the cyst. So whenever this happens, this may lead to fetal demise due to hypovolemia. So delivery by C-section is trying to be very careful not to cause this kind of situation. Yeah, so remember this very important condition, and it is managed properly. The fetal therapy involves coagulation of the communicating vessels to prevent fetal hydrops, because some fetuses will end up with hydrops fetalis from the sacrococcygeal teratoma. So very important to be able to assess the cardiac overload here. Then the prognosis, the perinatal mortality is 30 to 40%. Due to the issue of the hemodynamic instability associated with these conditions. The prognosis is poor, the poor prognosis is associated with a solid, malignant, and a large tumor. So this is how it looks like. This is a 3D rendered image. You can see here the tumor size. Yeah. So it varies. I think some of you have been with us long enough. We've seen together some sacrococcygeal teratomas. This is why it is important to always see the tip of the spine. You cannot say you've checked the spine if you don't see the tip. The tip has to be seen always, always. You cannot do a spine examination and not check the very tip, because you miss a sacrococcygeal teratoma. Cephalocele. How common are they? Incidence is 1 in 3,500 to 5,000. The diagnosis is normally a cystic structure of variable dimension protruding through a calvaria bone defect, through the skull bone defect. The calvaria, just to be learned, right? But it simply means skull bone defect. Most often in the hospital region with an meningocele, or without, where there is just a meningocele, brain tissue, without brain tissue. So brain means encephalo, right? Meningo means the membranes that cover the brain and the spinal cord. These are the meninges. So encephalo means brain. So where you see encephalocele means brain structure is there. When you are just saying meningocele, that means it's only the membranes which are there, and the brain is not in the cephalocele. So we can call it a cephalomeningocele, or we can call it a encephalomeningocele. Then the risk of chromosome abnormalities is high. The occur as high as 14 to 18%. So that means this couple has to be offered karyotype. The prognosis, mortality ranges from 30 to 50% for an encephalocele and from 5% to 15% for a meningocele. So these couples have to know this, and it's depending on the amount of brain protrusion. Sometimes it's lethal if probably more than 50% of the brain is outside, because it will be impossible to take it back. So you can see this cephalomeningocele here. There is a breakage in the continuity of the spar of the calvarium, and some meningocele is outside with some fluid. Then we this is just to show a large defect here where the calvarium where there's a cystic structure there, where there's a defect of the calvarium. Yeah, I think that is the end of my presentation on CNS defects. It is a large topic, as you can see. This topic is available on YouTube. I think our teams are posting it on YouTube. So please go and rewatch it over and over again. You have to know for your own sake so that you become more competent, because a time will come when some of you will become independent practitioners, where you'll be doing ultrasound scan in the short-term future on your own. And you wish you for this lesson to watch over and over it again when you come across cases. The moment you become independent, you feel the need to know. But you guys should know now. There's no need to wait to become independent. So go and watch over and over again this topic on central nervous system abnormalities. We covered more than 90% of what you are going to come across in your career is in scanning babies. So yeah. So I'll leave the room for questions. I think we have some few minutes to just answer questions online. But if there are no questions online, the WhatsApp platform is there for you guys to